Hi, very welcome to Neurology Video Journal Club. I'm Behnam Sabayan. I'm a vascular neurologist and a clinician researcher at the Hennepin Health Research Institute and assistant professor of University of Minnesota. And we are so lucky to be joined by my great colleague and clinician, Dr. Sevil Yaşar, who's the associate professor of medicine and neurology at Johns Hopkins University. Very welcome, Sevil.
Yes, pleasure to do this together with you today.
Yeah, thank you so much for joining. To start this journal club, we'll go over the title of this paper and also we'll briefly discuss key features of this paper in the coming slides. So today we're going to talk about a recent publication in Neurology on the association between fluctuations in blood lipid levels over time in relation to incident Alzheimer's disease and Alzheimer-related dementias. So the very first thing that we wanted to talk about is the background of this study. So we know that vascular risk factors such as hyperlipidemia in midlife are associated with high risk of Alzheimer's disease and related dementias. But we know that also vascular risk factors are more in a dynamic status rather than just a single measurement would reflect everything. That's why in this study, the researchers decided to look at the changes in blood lipid levels over time and look at the association with incident Alzheimer's disease and Alzheimer-related dementias. So this study is in the setting of a Rochester epidemiology program. This is a retrospective clinical cohort study that included participants from Olmsted County in Minnesota, and they were age 60 years and older. So the medical health records were used for this study. And the researchers excluded those who had baseline diagnosis of Alzheimer's disease and Alzheimer-related dementias. And also they wanted to include people who had at least 3 measures of lipid profile. Ultimately, more than 11,000 participants were included in this study, and lipid values, including total cholesterol, triglycerides, HDL and LDL were measured. And the main outcome was set as incident Alzheimer's disease and Alzheimer-related dementia as a primary outcome. And it was based on the ICD codes. So the population were followed until 2018 after a period of measuring these changes in the lipid profile. And the researchers use a measure of variability, which is variability independent of the mean. Basically, it takes into account standard deviation of changes in lipid profile, but factored in with baseline mean. The findings were interesting. Over 10 years of follow-up on average, about 21% of individuals develop incidence Alzheimer's disease and Alzheimer-related dementia. That's something that we can definitely discuss further. And the authors noted that those who were on the highest quantile of variation in total cholesterol and triglyceride variability had higher risk of incidence Alzheimer's disease and related dementias. But they did not find the same association in relation with LDL and HDL. In the fully adjusted model. So this is key features of this study, and I will get back to my colleague, Dr. Yaşar. What do you think about this study? And please help us to better understand the findings and what will be the implications.
So I think just come back to also to the background. And so this is the first, not the first study looking at total cholesterol and the dementia outcome. But the first study looking at triglycerides, LDL, and HDL. So that's why, and variability and dementia outcome. That's why this is a very important study. There's, as you know, there's more information needed about variability and you know that we both worked in the area of blood pressure measurement, that there is important findings showing that the variability is maybe more important, provides more important knowledge. So the one thing which kind of I try to also understand, why did the authors think about what is the biological mechanism behind the variability and their findings? And I was looking a little bit in the literature, and I was wondering what your thought was about that. The lipid variability. With hypertension, it's kind of, okay, there's elevated blood pressure, there's you're the vascular neurologist, there's the shear effect. But I was wondering, what is your hypothesis? They mentioned a little bit plaque instability. What do you think about the hypothesis?
Yeah, that's a great point. When I'm thinking about metabolic fluctuations or changes, the first thing that comes to my mind is different levels of homeostasis at one point to the other, and whether that fluctuations in the homeostasis level in metabolic profile, like BMI, weights, or lipid profile, whether that gives us a signal about something that's going on in the body and might affect the brain. As you mentioned, there's a good evidence that fluctuations in blood pressure due to hyperperfusion, shear stress can relate to damage to the blood-brain barrier integrity and cause vascular changes. But it's interesting that we can see also this variation is not only detrimental in terms of just blood pressure, but also other measures of cardiovascular risk factors.
Great. So this paper is also gives us a perfect excuse to talk about the use of medical health records for research. We both work in clinics. We use the medical health records, so we know exactly what goes into the medical health records and the pros and the cons for that. Do you want to maybe we can spend some time, what are the pros and maybe what are the cons, and maybe also what are the positives and the negatives for using this in research, and the strengths and the weaknesses maybe in the paper, what we should look out for?
Absolutely. Yeah, so this is, I think, is a very key point for this paper, that, and any paper, honestly, you need to know the population under a study. And the population under a study is originated from a retrospective clinical cohort based on medical health records. What does it mean is that this information is really heavily reliant on type of information that was entered to the system by the clinician, whether people or patients were just in that area, whether they got care other places. So this is a very practical way of doing clinical research. I think that will be definitely a very strength of this setting. But it comes with some limitations, because we know that when you run a cohort study, you are recruiting patients or participants for a specific research question. But this type of data comes from a non-specific clinical care, and that comes with the fact that registration of one diagnosis versus the other could be sometimes at the mercy of one clinician or the other, and that can introduce some sort of bias and sometimes underrepresentation, sometimes overrepresentation. Sevil, what do you think? Do you think for this specific type of question, is it good to use medical health records, or we need to stick to our classic cohorts that we have?
I think this gives us really a chance to, I think we should still use it. Because we can capture a large population, which is maybe unrepresented, and we will never be able to capture them by trying to recruit them. And sometimes, when we are underdiagnosing, which we are doing really, really there's research about that, how bad we are, especially in primary care, with diagnosing not only mild but even moderate dementia. When we do this and we are underdiagnosing, so the findings could be even stronger. Of course, we need to make sure that we correct for that, like the study actually did. So I think, with knowing that the weaknesses, I think using electronic health record is actually a very, very good start. And then we can maybe we can even do straight to clinical trials. So I think that's my 5 cents here.
Yeah, absolutely. That really reflects the real-time practice on one hand. On the other hand, we need to be cognizant about limitation in the type of information.
Yeah, exactly. So then let me ask you, throw the ball to you. This study population came from Ulster County. And of course, that is what, again, we need to be considering, with electronic health records. What do you think about the generalizability, particularly when we're studying vascular risk factors?
We are learning more and more that when we are looking at the brain and vascular risk factors, we need to take into account the diversity that exists in the population. And we need to take into account race, socioeconomic status, accessibility to the medical facilities, and all those factors. And it has been underappreciated, and now we are really realizing that how important and how influential are those factors in our research. And at the end, we want to kind of have the data that is really generalizable to different layers of the population and different populations within one country or one continent or the whole world. I think one thing that we need to keep in mind for this study is that data is coming from mainly white population with actually good healthcare system, and that might not necessarily represent total population or other populations. And we know that, for example, when it comes to high blood pressure, cholesterol control, and all those kind of vascular risk factors, this is even more prominent and important. I think my 2 cents here would be that we need to be aware that data from one specific population is not always replicable in other population, or might have different effect estimates.
I agree. So that's why the one way is to maybe repeat also the same analysis in a different area, region. For example, here in Baltimore, we can do it in our region, which is where the population is higher. The population is higher in African Americans. So coming back again to which we talked about, how we miss the diagnosis of people with mild Alzheimer's disease, which was a little bit my concern, and how it can be addressed. When I read this paper, and those people, this is for the clinicians who don't do research. We wanted to help them a little bit when they read this paper, that they can say, when they read it, they can be ensured that, yes, the authors actually took care of this. Because in this study, although they excluded participants with, who had an ICD code when the study was started, with any type of diagnosis of ADRD, but we could have participants who were already developing some form of mild cognitive impairment, or even had mild Alzheimer's disease when they were enrolled. So can you just teach some of our neurologists who are not maybe so routinely doing epidemiological studies, what do we usually do?
This actually brings up some memories for me. When I was, before starting residency, I was actually shadowing Sevil in her memory clinic, and I could see that how delicate and how detailed is the evaluation. to label the diagnosis of dementia and Alzheimer's disease. And that was really probably the highest level of care that you could see. And that's the very first thing, is that you need to really have a setting to come up with a diagnosis and to be able to capture the spectrum of Alzheimer's disease and Alzheimer-related dementias. My feeling is that when we just go with ICD codes to this level at the county data, probably we are just seeing the tip of the iceberg. And sometimes there's also misclassification. For example, you can have different types of dementia, or you can have depression, or you can have any sorts of mimics, or you can have post-stroke cognitive impairment. And then that ICD codes would go to the system, and then you are kind of labeling it as your main outcome. This tells me that the best way to do that is, of course, to use this information, but also maybe some sort of adjudication is needed to make sure that we are really capturing real events, not mimics. We are not over or underestimating the outcomes. What do you think?
Yeah, I agree. Actually, what I was hoping for, that we are what I'm trying to get out. The other way is also do some, and what the authors actually did, what we usually try to do to exclude from our analysis the people who got the diagnosis of an ADRD 1 year after we started 1 year after the first follow-up. And then 2 years after the follow-up. So if we have already people with a mild dementia diagnosis or a smoldering dementia diagnosis, so we exclude those, and the authors did it, and that did not change the results, which encouraged me that their findings were real. So that's the one way to also address it. But I agree with you. This study looked basically at all-cause dementia, so maybe the misclassification is maybe not a major concern, but in general, absolutely, when you look for Alzheimer's disease outcome, absolutely. But yes, dementia can also, depression can show up as pseudo-dementia, as we know. So,
that's an excellent point.
Yeah, very often. So a lot of fun when we read this paper and we talked about that, because this was a perfect example about epidemiological studies. There were some issues. We both work with pharmacoepidemiological studies also, of course. And the one thing was also struck me, that the authors only looked at lipid-lowering medication, how it affected basically at baseline and not during the study. And that made me wonder how, that bothered me a little bit, because I mean, lipid-lowering medications can affect A, the levels, B, as a vascular neurologist, over 5 years, you can have a new stroke, and there could be an indication for a statin, and that will affect your lipid level. A new diagnosis of diabetes is indication for a treatment, so that will affect your total cholesterol. So that we have to keep in mind, so that maybe that can alter, as a clinician, that it's a little red flag in my mind, that maybe if we would repeat the study, maybe I would definitely have to think about how to treat medication use in terms of lipid-lowering medication use. Absolutely.
The whole purpose of this study to look at the changes, variation from one measurement to the other. And the whole idea was to just not to stick to one measure, but we need to understand what is the driver for those changes, and whether those drivers or determinants of fluctuation also independently related to the outcome here, which will be Alzheimer's disease and Alzheimer's disease-related dementia. You're absolutely right. So if you don't take into account the events that happen in the interim of the follow-up time, we might miss the opportunity to take into account those very important clinical events that are related to higher risk of having incident dementia. I think one really learning point for me on this study was to not just stick, if you are interested in the fluctuations and changes over time of your determinants, also you should also think about changes would happen for your confounding factors in that time period as well. And I think medications and events, definitely anti-lipid medications and events such as stroke diagnosis, as you alluded to, would be very important. Sometimes, we are bound with limitation of epidemiological studies, and you have them, which is fine, but definitely there are some statistical approaches with sensitivity analysis, with stratified analysis, that you can show the readers that maybe the results are consistent if you exclude the stroke events or those who had changed with the medication.
Exactly. So, yeah, no, that's very important, like new stroke event, new heart attack event, new diagnosis of diabetes. And that could help also to help us to really, really show that it's truly the variation of this cholesterol. What's the chicken and what's the egg?
Yeah.
Are we truly talking about the fluctuation, or are we talking about the results of this lipid, new stroke, new heart attack, and so on? So,
exactly.
Yes.
So one thing that we know, and I remember that I also learned from you, was that we know that years and maybe decades before incident Alzheimer's disease, dementia, our body goes through changes. We have changed the body composition, even sometimes blood pressure drops. We lose weight, and I think that chicken and egg question is very important to see whether what we are seeing is just like a signal that what would happen in future, or it has a really causal association. And again, using and taking into account those confounding factors would be really helpful to tease out what is what.
Yeah. And sometimes we can, and sometimes it's not, and it's maybe an additive to make even matters more complicated.
Exactly. One interesting thing for me was to see these differential significant associations. On one hand, total cholesterol and triglycerides were related with the outcome, but HDL and LDL that we target in our clinical practice on a daily basis were not. So what do you think about that?
I was surprised, and I don't have an answer. Because yes, I mean, and I always try to teach the students and my mentees, the devil is in the details. So I was really diving into the tables and trying to see what's different. And I couldn't get my answers really, while the LDL and the HDL did not, result in any change. It wasn't the numbers. I don't have really a good answer for that. So, what about
I'm the
you?
same page. I'm the same page. We have a large population. Everyone had at least 3 measures. 10 years of follow-up. So I don't think there is necessarily a biological reason behind that. We know that mainly our treatments are targeting LDL more than anything else. So that's something I think, again, maybe it's good to be tested again in different populations.
Yeah, the only thing what I was looking when I saw the highest tertiary group was very interesting, because they had the highest number of people with stroke, the highest number of people with heart attack, the highest number of people with diabetes. So that already suspicious. They had the lowest triglyceride, the lowest LDL, but also the lowest HDL. So maybe if the HDL would have been higher, I don't know. So there is really a story which can be still explored. There's something in that group that needs to be, should be explored and can be explored. So, but yes, I don't know, and definitely there's much more to it, and I couldn't put my head around it. Maybe there are smarter people and they can help us out. So
there is something that I wanted to ask you to educate me and kind of tell more about it to our listeners. So you have done a great number of research activities in this area. Do you think when we are thinking about fluctuations or variation, do we need to take into account where we are starting with? Because if you start really high, you have more room to decline, or when you start very low, you can have room for going up. What did they do to kind of take into account where you were starting at? Was there adjustment for baseline lipid profile?
They adjusted for baseline. Yes, they adjusted for baseline. So that was good. They adjusted for baseline triglyceride, for baseline cholesterol, for all of them, which is usually you do. So perfect. And to take into that account. So I don't know what to do about that. So in terms of also, they did additional sensitivity analyses, again, looking at sex differences. There was no sex difference. They looked also at age differences. And they found that, it wasn't anything exciting other than when you become older, then they lost the statistical significance in the total cholesterol group, but it remained in the triglyceride group. I think it was a sample size. I'm not 100% sure. I don't remember, but I cannot really comment on that. And then the question is, would you do any additional, to inform you as a clinician and think, let's now forget that we do research, but as a clinician, what additional sensitivity analysis would you perform to help you as a clinician to make sense out of this? Would you do any additional ones?
I think as a clinician, I would be interested to look at the mediatory factors. For example, is development of diabetes is in the causal pathway. We know that diabetes is strongly associated with risk of AD and ADRD. How about instance of CKD, chronic kidney disease? We know that is also associated. I think we already talked about stroke and other cardiovascular events like heart attack or heart failure. One thing I will be very interested in will be whether are we talking about like a direct association, or there are some intermediate clinical events that kind of mediated these. And again, I think it would have been very informative if we had those sensitivity or maybe a stratified analysis.
Yeah, I agree with you. That seems to be the recurrent chicken egg, exactly. And there's another thing, we talk about lipid variability, but there's a human being, the whole person, and there's not just one, there's when the lipids are changing, maybe our BMI is changing, maybe our glucose is changing, our blood pressure is changing. Shouldn't we? I just read one of the papers from Korea from 2018. They looked at total cholesterol variability, also on glucose, blood pressure, 5 different metabolic variabilities. And because they're all in our body, and then they showed that with each metabolic marker variability, which increased variability, your risk for dementia increases. So when you have variability in all 5 markers, your risk for dementia increases by 70%. So also as a clinician, so we should think about there's not only this, but we are looking at the person as a whole.
Well, yeah.
We should think about, when we look at cholesterol, should also look at all the others, because very often they are coming hand in hand. When someone has increased lipids and strokes, there we should also think about the other things. As a clinician, that is for me also the other take-home message.
Absolutely. And especially when it comes to, the more we do a study and we learn from Alzheimer's disease and Alzheimer's to dementia, the more we learn that this is a really multifactorial condition. We've never been successful to just focus on one factor and then really solve the whole problem. Years of exposure to multiple risk factors play a role. And I think this is an extremely important factor to keep in mind, that when we are looking at an outcome such as Alzheimer's disease and related dementias, we need to have more comprehensive view about risk exposure rather than just one factor. If I may, I wanted to also add another thing. Again, I'm a neurologist and I'm biased, and we always look at the images. We look at the integrity of the heart-brain axis. We look at the brain volumes. We look at the lesions. I think one other informative piece of information would be to see whether these fluctuations in lipid profile are also related to cerebral small vessel disease, or hippocampal atrophy, or intracranial atherosclerosis disease. What do you think about that, Sevil?
Absolutely. And that's what their electronic health records are. Perfect. I mean, we don't have perfect imaging. We don't have research quality imaging, but you could have like basics, you can look at medial temporal atrophy. Maybe some of them even have coronals. And so you can see some of them. You could do some good imaging. So absolutely. And that would be one of when we talk about what could be the next step in following up this research. I mean, this was fantastic paper. And what could be the next step, following up this research? But that could also answer a lot of, the hypothesis. What is this one? What is driving this, the variation, what could be this? I agree completely with you. So definitely.
Yeah.
And because it's pharmacoepi is the bottom of my heart, I wish they would also look at the effect of other cardiovascular medications, because as I mentioned, these people also have not only high cholesterol, but they also have maybe they have high blood pressure, and they, those also have some effect on dementia risk, but it's okay. But this is a very important study, because which is one of the first studies looking at not only total cholesterol variability, but also triglyceride and HDL and LDL. And it was a large study. It used electronic health record, and which is very important. And I think this is maybe the future, because we cannot always fund observational studies. They can give us tremendous information. Now, how can we so the next step in terms of research is, as we summarized it, maybe repeated the same research in a study in a population which is more diverse. Maybe also include more information about medication, imaging, to get answers about mediation. Now, I will throw the ball back to you and tell us, how are we ready to translate from this study in our clinical? When we go tomorrow, when we walk in our clinic, what would you do when you see a patient who comes, you as a vascular neurologist and me when I go tomorrow to my memory clinic? What will you take in your memory? What will you take in your clinic with you?
I think this is a really great study to signal a potential important association. And it gives us an important message that we need to look at a trajectory, fluctuations or variation from one visit to the other. To be perfectly honest, I don't think this is ready to be translated immediately to our clinical practice, but I think this can kind of lay ground for more research and thinking. One thing that when I read such a paper, it's interesting for me because it said, hey, Behnam, next time when you are entering a diagnosis in the chart, be careful. This might be used for research and, you need to be very diligent about it. I think that's one of the take-home messages for me, that as a clinician, we need to be really focused in those information is going to be used in future, with AI and all developments. But I think we need to have a little bit more diverse population studies, better control of confounding and mediatory factors, neuroimaging studies. Any intermediate phenotype would be helpful. And ultimately, we need to have the clinical trials that show us that if you not only you lower levels of LDL, for instance, or total cholesterol, if you decrease the fluctuations, that will be also helpful to reduce the risk of dementia. I think it's a great trigger for future research, but not ready for immediate clinical translation.
Thank you. I think you summarized it perfectly. And I think we are ready for close up our discussion. And we want to thank everyone who watched our video. And if they have any question, you can contact us. Thank you, Behnam. It was wonderful.
Thank you very much. Learn as always.